Rheumatological involvement in other diseases. Many systemic diseases can affect the locomotor system, and many drugs may cause adverse locomotor effects. The most common examples are described here. Bone disease in sarcoidosis is described on page 608, hemophilia on page 972, and sickle cell anemia in page 952. Malignant disease. Malignant disease can cause a variety of non-metastatic musculoskeletal problems. One of the most striking is hypertrophic pulmonary osteodystrophy, characterized by claving and painful swelling of the limbs, periosteal new bone formation, and arthralgia or arthritis. The most common causes are bronchial carcinoma and mesothelioma. Bone scans show increased periosteal uptake before new bone is apparent on X-ray. The course follows that of the underlying malignancy, and hypertrophic pulmonary osteoarthropathy resolves if this is cured. Now, drug induced effects on the musculoskeletal system. Secondary gout, principal drug is thiazides, furosemide, alcohol. Osteoporosis, principal drug glucocorticoids, heparin, glitazones, aromatase inhibitors, gonadotropin releasing hormone agonists. Osteomalacia, principal drug are anticonvulsants, etidronate and pamidronate high dose. Osteonecrosis, glucocorticoids, alcohol. Drug induced lupus syndrome, procainamide, hydralazine, isoniazid, chlorpromazine. Arthralgias, arthritis, glucocorticoid withdrawal, glibenclamide, methyl-dopa, cyclosporin, isoniazid, barbiturates. Myalgia, glucocorticoid withdrawal, L-tryptophan, fibrates, statins. Myopathy, glucocorticoids, chloroquine. Myositis, myasthenia, penicillamine, statins. Cramps, glucocorticoids, ACTH, diuretics, carbenoxolone. Vasculitis, amphetamines, thiazides. Now, rheumatological manifestations of malignancy. Polyarthritis, dermatomyositis and polymyositis, hypophosphatemic osteomalacia, hypertrophic osteoarthropathy, vasculitis, connective tissue disease, Raynaud's syndrome, polymyalgia rheumatica-like syndrome. Now, endocrine disease. Hypothyroidism may present with carpal tunnel syndrome or rarely with painful symmetric proximal myopathy and muscle hypertrophy. Both resolve with levothyroxine replacement. Primary hyperparathyroidism is associated with osteoporosis and also predisposes to calcium pyrophosphate dihydrate deposition disease and to calcific periarthritis, especially in patients with renal disease. Diabetes mellitus commonly causes diabetic cheroarthropathy characterized by tightening of skin and periarticular structures, causing flexion deformities of the fingers that may be painful. Diabetic osteopathy presents as forefoot pain with radiographic progression from osteopenia to complete osteolysis of the phalanges and metatarsals. Diabetes also predisposes to osteoporosis, fragility fractures, adhesive capsulitis, Dupuytren's contracture, septic arthritis, and Charcot's joints. Acromegaly can be associated with mechanical back pain with normal or excessive movement, carpal tunnel syndrome, and Raynaud's syndrome, and an arthropathy 50%. The arthropathy mainly affects the large joints and has clinical similarities to osteoarthritis but with a normal or increased range of movement. X-rays may show widening of joint spaces, squaring of bone ends, generalized osteopenia, and tufting of terminal phalanges. It does not improve with treatment of the acromegaly. Now, hematological disease. Hemochromatosis is complicated by an arthropathy in about 50% of cases. It typically presents between the ages of 40 and 50 and may predate other features of the disease. The small joints of the hands and wrists are typically affected, but the hips, shoulders, and knees may also be involved. The X-ray changes resemble osteoarthritis, but cysts are often multiple and prominent, with little osteophyte formation. Involvement of the radiocarpal and metacarpophalangeal joints may occur, which is unusual in primary osteoarthritis, and about 30% have calcium pyrophosphate dihydrate deposition disease and or pseudogout. Treatment of the hemochromatosis does not influence the arthropathy and management is as described for osteoarthritis. Hemophilia can be complicated by hemarthrosis, which, if recurrent, can result in the development of secondary osteoarthritis. Sickle cell disease may be associated with bone pain, osteonecrosis, and osteomyelitis. Thalassemia may be complicated by bone deformity, especially affecting the craniofacial bones, and by osteoporosis. Now, neurological disease. Neurological disease may result in rapidly destructive arthritis of joints, first described by Charcot in association with syphilis. The cause is incompletely understood but may involve repetitive trauma as the result of sensory loss and altered blood flow secondary to impaired sympathetic nervous system control. The main predisposing diseases and sites of involvement are diabetic neuropathy, hindfoot, syringomyelia, shoulder, elbow, wrist, leprosy, hands, feet, tapes dorsalis, knees, spine. The presentation is with subacute or chronic monoarthritis. Pain can occur especially at the onset, but once the joint is severely deranged, pain is often minimal and signs become disproportionately greater than symptoms. The joint is often grossly swollen with effusion, crepitars, marked instability, and deformity, but usually no increased warmth. X-rays show disorganization of normal joint architecture and often multiple loose bodies, and either no atrophic or gross hypertrophic new bone formation. Management principally involves orthosis and occasionally arthrodesis. The figure 2466 shows wrist X-ray showing a neuropathic Charcot joint in a patient with syringomyelia. Note the disorganized architecture with complete loss of the proximal carpal row, bony fragments and soft tissue swelling.